we're going to define what ischemia is. And ischemia occurs when oxygen demand of myocardial cells are not met. Basically, the tissue is deprived of oxygen. That usually results from an obstruction of blood flow to the myocardium. And remember that oxygen is supplied to the myocardium by the coronary circulation, specifically the coronary arteries. And there are a couple of different ways in which the coronary arteries can become obstructed. Primarily, coronary artery blockage can occur due to atherosclerotic plaque, due to atherosclerosis. And remember that plaques are made of cholesterol and calcium deposits. Thrombosis, which is clot formation. Vasospasm is the closing down of an artery caused by the spasm in the smooth muscle surrounding the artery itself. Often, this spasm is mediated by local factors such as thromboxane A2. That's beyond the scope of this particular lecture. Loss of perfusion pressure. That's a decrease in blood flow due to a decrease in the overall pressure of the system. And that can usually be due to secondary causes such as bleeding. Think of it like in the summertime, if you're in a 5-story building and the fire hydrant is opened on the sidewalk in front of your building, it decreases the pressure of the system, it decreases the flow to your faucet. As long as we are on the topic of ischemia, I want to mention that not just the myocardium can become ischemic. Other tissues that require high perfusion, such as the kidney and the brain, may become ischemic as well. Perfusion is the amount of blood flow per cubic unit of tissue, and generally tissues with higher metabolic needs require high perfusion. I want to point out other mechanisms that can cause ischemia. That is, venous obstruction, generally due to a clot or embolus. A reduction in blood exiting tissue will slow down blood entering that tissue from the arterial side. This results in edema due to fluid being forced out of the blood. Symptoms of myocardial ischemia: demand-induced chest pain lasting anywhere from 30 seconds to 30 minutes. You'll see different definitions of this in different textbooks. One textbook actually had 15 seconds to 15 minutes. You would have pain or numbness that may radiate down the arm, neck, shoulder, or jaw. The patient may experience pressure, heaviness, or tightness instead of pain. Often you hear cardiac patients complain that it feels like an elephant sitting on their chest. Shortness of breath, diaphoresis, and dizziness may occur. So diaphoresis, of course, is the profuse sweating that is associated with ischemia. So the diagnosis of myocardial ischemia is actually quite similar to the diagnosis of many other diseases. It starts with a good history and physical examination of the patient. A history of the present illness can actually differentiate myocardial ischemia from other things that may be occurring in the chest, such as pulmonary embolism, pericarditis, pleuritis, costral chondritis, musculoskeletal disorders, and of course indigestion. So it's important that the clinician speaks to the patient and figures out what brought on this pain. Did you do something different? Were you involved in some kind of activity? Did you eat spicy food, for example, to rule out other aggravating factors? The resting 12-lead EKG might show ST segment depression or inverted T waves in cases of ischemia. Exercise stress tests usually increase myocardial oxygen demand. They're able to reproduce symptoms, and we can visualize ischemic changes on the EKG that will tell us, in fact, that the patient's discomfort was due to some kind of myocardial ischemia. Just want to let you know that myocardial ischemia, in fact, eventually can lead to myocardial infarction. We start with the normal, we go to an ischemic myocardium, and if that is not treated or addressed, the patient can actually infarct or have a heart attack. Therefore, we're performing very similar tests as we do to rule out myocardial infarction. So we look at the patient's cardiac biomarkers. We'll discuss a little bit later what specifically these biomarkers are, but we're drawing the patient's blood to see if there's any elevation in these cardiac biomarkers that might indicate muscle tissue damage, myocardial damage. An EKG stress test with no imaging is a pretty simple test that's performed. However, I have to say, because of 85% of EKG stress tests can be negative when in fact the patient is ischemic, there is the need to add some kind of extra imaging just to increase the sensitivity of the test. For example, we have the stress echocardiogram, in which we take a baseline ultrasound of the patient's heart. We ask them to walk on the treadmill while monitoring their EKG for changes, and we monitor the patient for symptoms as well. When the patient reaches peak exercise, they've achieved a good heart rate that's based on their age, called a target heart rate, and they are sufficiently tired. We stop the treadmill, ask the patient to lie down again, and we take another echocardiogram of the heart at peak exercise to see how well the ventricles are squeezing. If the ventricles are squeezing well, that indicates that they're generally happy with their blood supply, and therefore myocardial ischemia is not indicated. Nuclear stress tests involve monitoring the patient with an EKG and the administration of a radionucleotide, also known as an isotope, a radiopharmaceutical, or a radiotracer. This isotope is usually administered about a minute before the patient feels like they cannot exercise anymore via an IV, and we wait about 20 minutes for the isotope to get to where it's supposed to go, which is the myocardial tissue. We then place the patient under a special camera called a gamma camera that will detect the radiation from the isotope, and we can take two pictures. One picture while the patient has just finished exercising, and the other picture a couple hours later, the so-called resting pictures, and compare the two and try to figure out where there is what's called a cold spot or a dark spot in which there is no isotope, and that usually indicates a blockage in the coronary artery. For patients in whom we suspect myocardial ischemia and they're unable to exercise for some reason, either they have balance issues, they can't walk on the treadmill, they're amputees, or whatever other physical limitations they may have, we have pharmacologic stress tests. We have different pharmacologic agents that we can administer to the patients that will kind of trick the body into thinking that it's exercising. And usually pharmacologic stress tests aren't just EKG stress tests. Pharmacologic stress tests are combined with some sort of imaging, either nuclear imaging or echocardiogram. Two agents that I've listed there are dobutamine, which is generally done as a stress echo, and regadenoson, which is done as a nuclear stress test. There's several other agents on the market. These are just examples, and as you come across them in your careers, you can become more familiar with them at that point. So how do we treat myocardial ischemia? We reduce the cardiac workload. And how do we reduce the cardiac workload? We reduce the blood pressure, usually by vasodilation. Vasodilation opens up the blood vessels and reduces the workload for the heart. Think of it as trying to sip a very thick smoothie through a very thin straw. Doesn't work very well, and it actually involves a lot of work. Same way when the myocardium has to pump against very tensed vessels, the myocardial workload goes up. As you'll notice in the treatment of myocardial infarction, we do very similar treatments in myocardial ischemia. We want to reduce the anxiety of the patient by reducing chest pain. A lot of patients with myocardial ischemia or infarction tend to have a sense of impending doom or anxiety. We can reduce this anxiety by reducing the chest pain. We can increase the oxygenation of the blood by administering oxygen. We can reduce the level of thrombosis or the thrombotic state of the patient. We can either give fibrinolytics or antiplatelet medication or antithrombotic medication, depending on what's indicated at the time. Remember, thrombosis is a clot. PCI, of course, is most effective. It's percutaneous coronary intervention, also known as cardiac catheterization. We can directly visualize the arteries and perform an angioplasty to clear the blocked blood vessels. And this is by far the gold standard in terms of treating myocardial infarction and ischemia if so indicated. Now, all these interventions are, as I said before, are quite similar for myocardial infarction, with the exception of the stress tests. When a patient has a myocardial infarction, we do not want to stress them at all. So I will be reviewing these interventions under myocardial infarction. What is a myocardial infarction? It's a heart attack. It's a condition that causes permanent injury to the myocardium, or basically a part of the myocardium dies. Part of the myocardium undergoes tissue death or necrosis. Necrosis and infarction are quite similar terms. It's not a class in cell biology or histology, so we're not going to go into the fine detail. What causes myocardial infarction? By far and away, the most common cause is a blockage in the coronary artery that feeds that particular part of the myocardium. Coronary artery blockage is usually a result of coronary artery atheromas, or plaques, due to atherosclerosis. Atherosclerosis of the coronary arteries is called coronary artery disease. Some textbooks call it coronary heart disease, and some textbooks refer to it as ischemic heart disease. The question then becomes, what causes atherosclerosis and the formation of atheromas? Well, there are several risk factors. So please note that atherosclerosis is a form of a disease called arteriosclerosis. Atherosclerosis is a type of arteriosclerosis that affects medium and large arteries. If we look at this diagram here, we can see the formation of a plaque. And the caption says, plaque is an irregular accumulation of cholesterol and fat that closes off blood vessels. If you notice, the next diagram is how a thrombus takes shape. Why are we discussing thrombi when it comes to coronary artery disease? Because actually a very high percentage of myocardial infarctions are caused when an atheroma, this plaque, damages a part of the blood vessel wall. It ruptures the wall and it exposes collagen. Once collagen is exposed in the blood vessel, that is the initiation of clot formation. Already we have a blocked blood vessel that is something like 70 to 90% blocked. Now that atheroma or plaque ruptures the blood vessel wall and we have a clot forming on top of that. That is what occludes or closes off the rest of that particular blood vessel and causes an MI. So what are some risk factors for atherosclerosis, ischemic heart disease, and myocardial infarction? Well, we have a pretty decent mnemonic that helps us remember, and it's called HAS lipids. The H stands for heredity. One or more parents having some kind of cardiac event. That's why physicians usually inquire about the health status of both parents and or any siblings. Are they alive? Are they dead? What ages did they pass and what caused their deaths? A is for age. For males over 45 and females greater than 55, there is increased risk for MI. Sex. Generally, men are predisposed to myocardial infarction over women until about the age of menopause. Lipidemia here refers to hyperlipidemia, and generally an LDL of greater than 160 milligrams per deciliter, or an HDL of less than 34 milligrams per deciliter, or total cholesterol to HDL ratio of greater than 5 in men and 4.4 in females is above average risk for developing coronary artery disease. The I stands for increased weight, being overweight, particularly having a pear-shaped body with a lot of what's called central obesity. P stands for pressure or hypertension. That puts a lot of extra work on the heart. I for inactivity. Doesn't matter how healthy a diet you eat. If you're inactive, your heart is a muscle and you do not use that muscle, it will basically atrophy on you. Diabetes for several different reasons. Number one, patients who are diabetic tend to be in what's called a procoagulant state. Number two, diabetic neuropathy usually masks the symptoms of chest pain. And smoking for many reasons, but one of them being because it tenses up the blood vessels and increases blood pressure. What are the symptoms of an MI? Well, they're quite similar to myocardial ischemia. And when we go 2 slides down, we will see the distinction between ischemic pain versus pain of an infarction. But let's go over the general symptoms now. Angina pectoris, which is chest pain, and there are 3 types. There's stable angina, that's the most common form, precipitated by some kind of activity, or it can be actually precipitated by stress as well. And it usually resolves with rest in about 20 minutes. Unstable angina, this is usually pre-infarction angina and is characterized by pain at rest that increases not just in severity, but increases in frequency with activity. And Prinzmetal's or variant angina, caused by a spasm of the coronary artery, it's characterized by intermittent chest pain at rest. Again, we have another mnemonic for you. MI symptoms, dance pad. Dyspnea, anxiety, nausea and vomiting, crushing substernal chest pain, elevated temperature, pallor, arrhythmias, which are irregular heart rhythms, and diaphoresis, which is sweating. I don't like this particular description of the symptoms per se, but actually it is a useful mnemonic. Here we have that figure that I promised you, distinguishing angina pectoris from myocardial infarction. And we see that they both have substernal pain across the chest. They both have neck, jaw, arm, back, and shoulder pain. And the nature of the discomfort can be either dull or heavy, or a pressure with a squeezing sensation in ischemia. But it could be the same in infarction, but usually more intense. The duration of angina pectoris, and again, this will vary from textbook to textbook, usually 2 to 15 minutes subsides after activity stops. The pain of myocardial infarction usually lasts 10 minutes or longer. Some textbooks say 20 minutes. If it does not resolve after 20 minutes of rest, take yourself to the emergency room or go via ambulance. Other symptoms, usually with ischemic pain or ischemic angina, there's not a whole lot other things going on. But with myocardial infarction, the patient is pale, gray, nauseous, weak, dizzy, lightheaded, and of course diaphoretic or is perspiring a lot. As far as factors giving relief, in terms of angina pectoris or ischemic chest pain, stopping physical activity, reducing stress, and nitroglycerin usually help. Nitroglycerin is a vasodilator. In the pain of myocardial infarction, nitroglycerin may give incomplete or no relief at all. As long as we're on the topic of myocardial infarction symptoms, I want to mention something called ACS, acute coronary syndrome. Acute coronary syndrome is a fairly new term, and it's applied to patients in whom we suspect myocardial ischemia. The term covers what's called an ST segment elevation MI, or a STEMI, or a non-ST segment elevation MI, and patients with unstable angina. Patients with unstable angina often have an MI with no ST segment elevations and may not have elevation in cardiac enzymes. This is why we came up with the term ACS, because certain patients present in a very atypical way where we'd normally suspect myocardial infarction with EKG changes and elevation of cardiac biomarkers or cardiac enzymes. Some patients don't present that way at all. So we came up with the term ACS to cover those patients. A lot of times you may see this diagnosis written up as rule out ACS. So we're going to talk about diagnosis of an MI. We usually see EKG changes in 85% of cases, but they're usually non-specific. In about 50 to 65% of cases, diagnostic changes occur within the first 2 days. So we can see non-specific changes that really don't mean anything. They're kind of atypical in about 85% of cases, and only in as little as 50 to 65% of cases are there what we call diagnostic changes, changes that meet the diagnostic criteria for an MI. Again, that drives home the point of why we came up with the term ACS, acute coronary syndrome. By far the gold standard is cardiac troponin or troponin I. It's most relevant and it's drawn at intervals of 0, 2, and 6 hours depending on the hospital's protocol. Some hospitals still use myoglobin and it elevates between 2 and 4 hours. Creatinine phosphokinase MB or CKMB elevates at 6 hours. AST elevates within 12 hours, but it's seldomly used. Some hospitals use lactic dehydrogenase, LDH flip, and that usually occurs within 24 hours. The reason it's called LDH flip is because in the blood, LDH2, which is a particular form of this enzyme or protein, is usually higher than LDH1. Whenever we have myocardial damage, that is reversed. LDH1 becomes higher than LDH2. If any cardiac biomarkers are elevated, damage has occurred, and stress testing, of course, is contraindicated. This is a person who has a myocardial infarction. Part of the heart muscle has died. We do not want to stress the heart at all. And use the term enzyme and cardiac biomarkers with the understanding that these are proteins that are normally within the heart muscle tissue itself. And when the heart muscle tissue dies, it starts leaking these proteins circulating in the blood. This is why we're describing the different time intervals in which these proteins or enzymes are elevated. If, of course, we do an echocardiogram, we can see certain parts of the myocardium contracting abnormally, something called a wall motion abnormality. So this is a nice diagram that I found. It's a progression of an acute myocardial infarction. And it says an acute MI is a continuum that extends from the normal state to full infarction. This is something that I may have mentioned before. It says ischemia is lack of oxygen to cardiac tissue, represented by ST segment depression, T wave inversion, or both. An injury, an arterial occlusion with ischemia is represented by ST segment elevation. That is an infarction. Okay, that's an acute infarction. We will see ST segment elevation. So that's why certain MIs are called STEMIs, ST segment elevation MIs or STEMIs. And this particular diagram says infarction, death of tissue, is represented by what's called a pathologic or disease-associated Q wave. As a matter of fact, old terminology would call a STEMI a Q wave infarction and an NSTEMI a non-Q wave infarction. But the newer terminology is just STEMI and NSTEMI. I want you to know that we can detect old MIs as well on EKGs. Sometimes patients may have silent heart attacks and may have not gone to the hospital or sought attention for them, and we can detect them by the appearance of pathologic Q waves on an EKG that did not have pathologic Q waves before. Here's some diagnosis of an MI lab tests. A lot of these may be done at different facilities. The most common ones, of course, are CK-MB and troponin. This particular table lists troponin T, but troponin I seems to be more specific for myocardial tissue. You can look through this table. You do not have to memorize the normal or reference ranges, but you should also look at the significance of the abnormal values. This is a useful diagram describing ST segment elevation and depression. I want you to appreciate that not all ST segment elevations are due to MIs, and not all ST segment depressions are due to ischemia. There are other diseases that can cause ST segment elevation and depression, and here are some examples. Early repolarization, or what's called normal variant in young adults. Pericarditis is inflammation of the pericardium. Ventricular aneurysm, pulmonary embolism, and intracranial hemorrhage are some causes of ST segment elevation. Interestingly enough, there is actually very simple differential diagnosis for distinguishing pericarditis from myocardial infarction. When the physician auscultates, they will hear what's called a friction rub upon auscultation. And if they ask the patient to lean forward, the patient is going to get some kind of relief from his chest pain. Of course, they're going to do confirmatory tests, but this is why I always say a good diagnosis starts with a good history and physical exam. So we move on to treatment of an acute MI. We start with cardiac catheterization, also known as percutaneous cardiac intervention, or PCI. It's so called because this procedure can be used to produce many interventions. In the treatment of an MI, PTCA, percutaneous transluminal coronary angioplasty, is the most successful when what we call door to balloon time is 90 minutes. That means from the time the patient walks in the door to the time they actually get the balloon inserted into the blocked coronary artery is within an hour and a half. So percutaneous means through the skin. Transluminal means across the lumen of a blood vessel. The lumen is the center part, the empty opening that the blood is supposed to flow through. Coronary, of course, referring to the blood vessel surrounding the heart. And angioplasty means surgical repair of a vessel. Just a quick overview of PCTA. The catheter is placed in an artery and a guide wire is advanced across the coronary artery blockage. A balloon is inflated that compresses the blockage. A dye is usually administered before and after the balloon inflation just to check the condition of the coronary artery and to make sure that the procedure was successful. Most PTCAs that are performed in today's cath labs are done with stent placement. And a stent is the mesh scaffolding that is placed inside the artery to keep it open. Other interventions that can be performed with PCI, for example, pressure measurements in the chambers and blood vessels. Depending on which pressures you want to measure and depending on which chambers pressures you want to measure, you may have to do either a left heart catheterization or a right heart catheterization, and that has to be coded for differently. Arthrectomy is actually removal of the artheroma, and angiography. Angiography is known as a diagnostic cath, and it's described as an angiography when there's no interventions performed. In other words, this patient presented with symptoms of myocardial ischemia and infarction, but their coronary arteries were in fact clear. So here we have a nice diagram illustrating the different points in which the catheter for PTCA might be inserted. We have the arm insertion site or the brachial artery. We have the wrist insertion site or the radial artery. And we have the groin insertion site or the femoral artery. And we also have a picture of the catheter there. Depending on how the cardiac intensivist is trained, that's where he's going to insert the catheter. Also might depend on the hospital's protocol. Showing what I mean about angioplasty pictorially, I just wanted to let you know that it opens clogged arteries, and it does so by compressing the plaque against the artery wall. The catheter with a small balloon at its tip is moved into where the artery is clogged. The balloon is inflated and then deflated a few times. This compresses the plaque, opens the artery, and increases blood flow. Then the catheter is removed, and a stent is usually placed to keep the artery open. Here are some interesting pictures here for you. These are taken from an actual procedure. You see the narrowed artery right there, and you see the normal artery right there, and that's the point where we have blockage. The other picture is that of a ventriculogram. Okay, so what can we do to treat this patient until the cardiac interventionalist is there and can actually perform PCI? The mnemonic is MONA: morphine, oxygen, nitroglycerin, and aspirin. Morphine to relieve the chest pain, oxygen to increase the oxygenation of the blood to the myocardium, nitrogen is a vasodilator to increase blood flow to the myocardium, and aspirin to prevent the formation of clots if they haven't already been formed. If we suspect clot formation, we can give fibrinolytics. These are medications that are used to dissolve a clot once it has already been formed. Two examples are streptokinase and urokinase. So some patients are not candidates for angioplasty. Usually if they have a very high-grade stenosis, they have so much blockage of the coronary arteries that it cannot be addressed by angioplasty and stent placement. These patients have to undergo what's called CABG, coronary artery bypass graft. A new artery is fashioned usually from a vein. The two main candidates are the saphenous vein in the leg and the internal mammary artery in the chest. It is grafted onto the aorta and then onto the myocardium to supply the oxygen-starved muscle. It's also known as OHS, or open heart surgery. We have an abbreviation to designate how many grafts the patient get. C2L, for example, stands for CABG 2 Lima, meaning that the patient has received 2 coronary artery bypass grafts. What you're doing here is you're bypassing the blocked native coronary arteries with grafted arteries, hence the name. This diagram is provided to show you what a bypass graft looks like and also what a stent looks like as well. I've provided you with this particular diagram that summarizes what the coronary artery bypass graft is and has some actually good examples of bypass grafts. That is the end of the lecture. We are going to address different ways to reduce the myocardial workload by vasodilation and treating hypertension in a different lecture. If you like this lecture, please like it on YouTube and subscribe. Thank you.